Thank you for being here. I am going to talk about further evaluation of dementia in primary care. My learning objectives for today is to identify, describe, and demonstrate some common cognitive evaluation tests that we use, to describe some elements of physical examination and also the laboratory testing and the diagnosis of dementia in the primary care setting. I think a lot of the information that we're going to present is going to overlap some, so I'm going to kind of just browse over things that we're already talked about. But why geriatrics? We know that the oldest of the US baby boomer generation turned 65 on January 1st, 2010. And for the next 19 years, starting in 2010, every day another 10,000 persons will turn 65 in this country. So by 2030, the country's population of seniors will double to about 71 million individuals, which means that 1 out of 5 people will be 65 and older at that time. What are our resources? Like Dr. Renfrew said, this is older data, but it hasn't changed much, unfortunately. Currently, there are about 7,000 physicians in the US who are certified geriatricians. By 2030, we would need an estimated 36,000, but we also know that only about 250 new geriatricians are graduating yearly from fellowships. So that means up until 2030, it's less than 4,000, so it's going to be a big problem. So that again takes us to what Dr. Renfrew said and other people said, that it's going to be getting to the point where all of us will be doing geriatrics. The problem of dementia, we know that its prevalence increases geometrically with age, and by age 85, it affects about 50% of the individuals. This was already presented, the problem of silent dementia, the fact that families are oftentimes not aware and physicians fail to detect dementia in its early stages or mild cognitive impairment. So to screen or not to screen for dementia, given the fact that the risk of Alzheimer's dementia increases with age, older adults seem to be a natural choice for screening. However, the US Preventative Services Task Force currently does not recommend screening in asymptomatic patients, and they say that we don't really have good screening measures. There are biases for education and age, and there's little to do for treatment. We know that for a screening test to be considered good, we have to have a disease that's prevalent, and we have to have some type of treatment that's effective on top of a good screening tool. So these are the reasons why they do not recommend. However, the Alzheimer's Association Advisory Group does recommend screening at the Medicare annual wellness visit, and it's a two-step process where we screen with either a mini-cog or an AD8 or the general practitioner's cognitive evaluation. And if that screen is positive, then we would do more evaluation with either a MoCA or a SLUMS, and then we would test the labs and do a depression screen and do a neurological exam. The alternative would be to refer to a dementia expert. So let's say we have a 77-year-old retired teacher who presents to our office reporting worsening memory for the past 3 years. She has a history of breast cancer. She right now only takes a multivitamin and calcium. She's been asking the same questions repeatedly. She gets her appointments mixed up. She's forgotten to pay some bills recently, and she has difficulty using a new cell phone that her family purchased for her. What would you do? Would you screen in a situation like this? I think I would. So moving forward from here, what I will work on presenting is based on 3 of the ACO indicators. One is the one that if a vulnerable elder tests positive for dementia, then a physician should document an objective cognitive evaluation that tests 2 or more cognitive domains. And then if a vulnerable elder is newly diagnosed with dementia, then a physician should perform a neurological exam. And the third being that if a vulnerable elder is newly diagnosed with dementia, a physician should perform several laboratory tests, and I will go through them. So as I'm walking through this talk, I'm going to show you some paintings. This is a United Kingdom-based artist who was diagnosed with Alzheimer's disease in 1995, and before he died in 2007, he created a series of self-portraits, documented the gradual decline in his cognition. This is one of his earlier self-portraits in 1967. Again, he was diagnosed in 95. This is an early one after his diagnosis in 1996. So I'm going to go briefly over the mini-mental state evaluation, then I will talk in a little more detail about the MoCA, the Montreal Cognitive Assessment, and also briefly about two other tests that we sometimes use. The mini-mental, as we all know, it's copyrighted by the Psychological Assessment Resources, and if it's not memorized by the clinician, then we should use a purchased or an approved copy. It's easy for us to do it all the time to memorize it, but then again, we also teach, and we cannot teach if we don't actually have the forms. So we have gotten away from this, but it's still fairly widely used, so that's why I'm presenting it here. So again, because most everybody knows it, I'm not going to talk a lot about it. It's a 30-point scale that evaluates orientation, then attention and calculation, registration, delayed recall, and then verbal and visual spatial skills. It is subject to education in language, in vision and hearing, so that limits its use some. So we have questions for temporal orientation, the year, the season, the month, today's date, and the day of the week. You get 1 point for each correct answer. We have spatial orientation, the country, the state, or the state and the county, the city. If we're doing it in home, the street address. If it's in a facility, the name of the building. And what room if we're in a home, or what floor if we're in a facility. And again, there's 1 point for each correct answer. The next one is about registration. You'll say 3 words slowly at the 1 second interval. I'm kind of like Dr. Helen, so I have to use something that I always use, because otherwise I forget what I told them. And you will give them 1 point for each correct answer. You will repeat all 3 until they are learned. The next ones are attention and calculation, either serial 7s or spelling world backwards. There's 1 point for each correct answer, and you stop after 5 subtractions, but you give 1 point if we have a correct subtraction, even if the previous answer was wrong. So if they go from 100 to 93 and then they do 85, if the next one is correct, you will give them that point. You will then do delayed recall after the attention and calculation tests. Ask them about those 3 objects. They get 1 point for each correct answer. This is considered to be the best actually in the mini-mental, in that if the patient recalls less than 2, so 1 or 2 of the objects, and their likelihood of having a dementia diagnosis is quite high, as opposed to when they recall all 3. And again, this was discussed briefly with the mini-cog. And then the language tasks, where you show them a wristwatch and a pencil. You have them repeat a phrase. You have them follow a written command. So you write something like close your eyes on a piece of paper and have the subject read it, but they have to also follow the command. So if they do not close their eyes, you can repeat it, but you only score it if they do close their eyes, so if they do follow the command. Then you ask them to write a sentence, to copy interlocking pentagons. For that, we know that you only score if you have 2 5-sided figures and they interlock, forming a 4-sided figure. and then the 3-step command where you ask them you give them the command and ask them to follow each step. You give them 1 point for each correct step of the 3-step command. So let's look a little bit about the sensitivity and specificity of the mini-mental. This is for mild cognitive impairment. So its sensitivity for for mild cognitive impairment is low. What does it mean? It means that even patients who have a negative test, so score within normal range, may have a diagnosis of mild cognitive impairment or mild dementia. It does have a high specificity, however, which means that if you have a score below 27 or 26, it's likely that there is a real problem going on. There are scores that you can adjust for age and educational level, so you can do that. And this is just a basic scoring, and I will not go into this too much. I'm just going to show you some more pictures. So this is 1997, and another one from the same year. And I'm going to talk a little more, because I was asked to, about the Montreal Cognitive Assessment Test. I think we use this most frequently. They say that it's a 10-minute test. I don't think I've ever been able to administer it in 10 minutes. It is a 30-point cognitive screening test that is useful in detecting mild cognitive impairment and dementia. I will show you some tables about its sensitivity and specificity relative to the mini-mental in a second. The very good thing about it is that it is available in the public domain, so anybody can access it. It's available in multiple languages and in several versions. So if you test a patient repeatedly and they may remember that we asked them about the camel or something, you can use a different version the next time. So the entire test and the instructions, very detailed, are available at this website. So this is what it looks like, and I will break it down in sections. As we think back to the ACO indicators that we need a test that a screening tool that tests at least 2 cognitive domains, this test does that. So we have physiospatial and executive tasks. We have language with the naming. We have memory. We have attention. We have more language. We have abstraction, and then memory with delayed recall and orientation. So the first 3 that were already mentioned are the trail making, the mini trails, the copying of a geometric figure. The first version is with a cube, and drawing of a clock. So the alternating trail making, you instruct the subject to draw a line going from a number to a letter, and in ascending order. They have to start at 1 and finish at E. You tell them where to begin, and then you tell them where to end. You give them 1 point if they do the pattern in the correct order, so 1A, 2B, and so on, without drawing any lines that cross. And if they make any error that they do not correct immediately, you don't give them a score. So it's a the whole test, if you go by the instructions, it's pretty strictly scored. The second one under this category is the visual constructional skills of copying a cube. You show them the cube and you tell them copy this drawing as accurately as you can in the space below. You give them 1 point if all of these criteria are met. So it needs to be a 3-dimensional drawing. All lines need to be drawn. No lines should be added. And lines are relatively parallel. If they draw a rectangular prism, that's acceptable. They don't have to have exactly the same length, their lines. The third one is the clock. This was already discussed. The difference from the mini-cog is that they actually have to draw the contour themselves. And you had actually mentioned that you do this anyway. You tell them draw a clock, put all the numbers in, and set the time at 10 past 11. And you give them 1 point for drawing the contour correctly, putting all the numbers in correctly, and putting the hands in correctly. So again, it's strictly scored because they have to have a full circle. The numbers need to be all the numbers, no numbers added in the correct place on the clock. And the hands, you have to have a shorter hour hand, a longer minute hand. You have to have them unite towards the center of the clock. So it's difficult to get a perfect score on this. The next one is naming. You show them 3 animals and you ask them to tell you the name of these animals. Again, the animals vary on various versions of the test. The original one shows a lion, a rhinoceros, and a camel. And you give them 1 point for each correct answer. The next one is memory. You read them a list of 5 words at the rate of 1 word per second, and you tell them beforehand, this is a memory test. I'm going to read you a list of words that you'll have to remember now and later. Listen carefully, and when I'm done, tell me as many words as you can remember. It doesn't matter what order you say them. You do 2 trials with similar instructions. You can actually mark on the test form which words they've gotten correct for registration. But unlike the mini mental, you do not score the registration part here, so you don't give them any points for this part. And then we go into the attention tasks. So we have the digit spans here. We have forward digit span. You tell them, I'm going to say some numbers, and when I'm through, I want you to repeat them to me exactly as I say them. And you read 5 numbers. I think they're 2, 1, 8, 5, 4, and they're supposed to repeat them. And then you have a backward digit span. You tell them, I'm going to say some more numbers, and I'm going to ask you to repeat them to me in backward order. So you say 7, 4, 2, and they're expected to repeat them in a backward order. You give them 1 point for each of these 2 tasks. And then the next one is an attention or a vigilance test. We call it the A-SLAP. So you're going to tell them, I'm going to read you a long list of letters. And every time I say the letter A, I want you to tap your hand or lift your finger or show me a sign that you've heard that letter. If I say a different letter, then do not tap your hand. You give them 1 point if they have 0 or 1 error, and if they have more than that, then you do not give them the point. So what we usually see, there's either omission errors where they do not tap for this letter A, or commission where they tap for more than 1. If it's omission, it's more likely related to an attention deficit. If it's commission, it could be that they just cannot inhibit what they had learned, so it's maybe more evident of dementia. Also under attention tasks falls the serial 7 test. It's similar with the mini mental. The only thing is that the scoring is different. Here you can only get a total of 3 points. So, and again, each subtraction is evaluated independently. So if they get all 5 correct, then the maximum that they can get is 3. So if they get 4 or 5 correct, they get 3 points, and then you take away points. The next task is about sentence repetition in the language area. So you ask them to repeat a sentence. You tell them, I'm going to read you a sentence, and I want you to repeat it after me exactly as I say it. The first sentence is, I only know that John is the one to help today. And the second is, the cat always hid under the couch when dogs were in the room. You give them 1 point for each sentence that's repeated correctly, but the repetition needs to be exact. For example, If they say, I only know that John is the only one to help today, you cannot give them the point. If they say the cat always sits under the couch when the dogs are in the room, again, you don't give them the points. So it's very strictly scored. The next language task is verbal fluency. So you tell them, I'm going to ask you to tell me as many words as you can think of that begin with a certain letter. I'm going to give you that letter in a moment. I'll tell you to stop after a minute. I don't want you to tell me proper names. Sometimes you have to explain that. So I don't want you to tell me names of people or names of places and not use the same, different endings for the same word. And then you tell them that their letter is F and give them 60 seconds to tell you as many as they can. In order to get a point on this test, they have to come up with at least 11 words. Then we have the abstraction tasks. So the first one is tell me about how an orange and a banana are alike. This one is not scored. So if they don't come up with the correct answer, then you can tell them that it is fruit. And then you don't give them any other additional instructions beyond that. So the purpose of this orange and banana is to show them what you're actually expecting from them. And then after the practice trial, you tell them, now tell me how a train and a bicycle are alike and how a watch and a ruler are alike. You don't give any additional instructions or prompts on this one. How do you score? You give 1 point for each pair of train and bicycle and watch and ruler. Acceptable answers are for train and bicycle that they're both means of transportation, or you travel, or you can take trips in both, but not that they have wheels. So that's the concrete answer. For ruler and watch, ruler and watch, that they're both measuring instruments, but not that they both have numbers. And then this is the most difficult of the tasks on this test, the delayed recall. So you tell them, I read you some words earlier, you repeated them after me. Please tell me as many words as you can remember. And you make a check mark for each of the words that is recalled spontaneously without any cues from the examiner. So those are the only words that they get a point for. So they can get a maximum of 5 points on this part. You can use category cues or multiple choice within category cues. However, you don't give them points for that. So what's the purpose of it? It can give you more information about the type of memory disorder. So we know that when we think about memory, we think about encoding, storage, and retrieval. The encoding and retrieval part mostly have to do with our frontal lobe and attention and the executive function. The storage part mostly has to do with our hippocampus, so that's usually affected in Alzheimer's disease. So patients who have a storage problem, they cannot improve their scores on this, or they cannot improve their performance at these tests, on this task, even if you give them cues. So it doesn't really matter. For deficits of retrieval or encoding, then their performance may improve with giving cues. So this is why we use it. And then the last part of the MOCA is orientation. You start by asking, tell me the date today. And if they're not able to give you the complete answer, then you break it down. Tell me the year, tell me the month, tell me the exact date, the day of the week. Tell me the name of the place and which city it's in. So they can get a total of 6 points on this one. They must tell you the exact date and the exact place. So you don't score them if they're not exactly on the same date. So I was saying that I was going to show some data regarding the sensitivity and specificity of the Montreal Cognitive Assessment Test in comparison with the mini-mental. As we can see here, for mild cognitive impairment, the Montreal Cognitive Assessment Test is significantly more sensitive than the mini-mental. When we get into the Alzheimer's dementia range, the difference is not as evident. For specificity, the numbers are similar, so there's not such a big difference. So the problem is mostly with mild cognitive impairment, which means that if we have a negative test, so the patient scores above 26 on the mini-mental or in the 24 to 30 range, we should test with something else because we cannot rely on that to rule out mild cognitive impairment. We cannot rely on the mini-mental to rule out mild cognitive impairment. The slums was mentioned earlier. This is the St. Louis University Mental Status Examination. We have recently started to use it more often. Like you can see here, it has orientation tasks. It has a memory part where they have to remember 5 words. There's a calculation and attention part. There's a naming part, naming as many animals in 1 minute as they can. The digit part, which is similar with the other tasks, clock drawing, face, drawing of a clock, recognizing, so visual spatial for geometrical forms, and you tell them a story and they're supposed to listen and answer some questions after that. This is how you score it. It has high sensitivity for dementia. In patients who have less than high school level of education, its sensitivity is about 86%. Goes up to 98 for the ones who have a high school level of education or more. For mild cognitive impairment, again, the numbers are not as good, so the sensitivity is about 78% if the patients have less than high school level of education, and about 55% if they do have more education. Another test that we sometimes use is the executive interview. This is a more time-consuming test. It has 25 items, and they say it's about 15 minutes, but again, I think it takes a lot longer than that. You score between 0 and 50, so the higher scores are worse. You can get 0, 1, or 2 for each item. 0 is if you don't have impairment, 2 if you are significantly impaired. Normal young adults rarely score more than 7 on this test. If we have a healthy elderly patient, I think the cutoff is about 15. So if they go above 15, that there's usually an impairment. What we've used it for is for correlation with the need for nursing home placement. So if patients have high scores, they're more likely to need more assistance. So I was going to show you some more of the paintings as his disease progressed. So this is 1998, both of them. And I want to move on to what the laboratory tests are that we usually use in the workup of dementia. We want a complete blood count. We want a complete metabolic panel, looking at the electrolytes, at glucose, at BUN. We want the B12. We ask for thyroid function tests. We ask for a syphilis testing, especially if there are risk factors. I haven't seen a positive test yet, but there's good data now, especially from states that have a similar population as ours. For example, in Florida, where it appears that elderly patients do engage in sexual behaviors that put them at risk of developing sexually transmitted diseases. So it makes sense to test if we think that there are risk factors. HIV testing, if we have a new diagnosis, or if again the patient has known risk factors. And sometimes drug levels of certain medications are also helpful. The Alzheimer's Association has an app for what labs should be ordered, so that can be accessed. In terms of neurological examination, again, the ACO indicators ask for certain things that should be tested during a neurological exam. What we do during a routine evaluation in our clinic for neurological exam is we test cranial nerves, we test muscle strength and tone, deep tendon reflexes, plantar reflexes, we test for Parkinsonian signs and pathological reflexes, frontal release signs like the snout reflex or the palmomental reflex. We test the cerebellar function and also gait and balance. Now, what's the yield of this examination? A lot of times, some of these findings are inconsistent, like focal signs suggesting strokes or Parkinsonian signs. We don't really have any early supportive neurological signs for a diagnosis of dementia. What's supportive? It's usually found in the mid to late stages of the disease, and none of these listed here, including snout or grasp or palmomental reflexes, are actually sensitive or specific, so they're not really very helpful. So just this past January, I went to a Harvard course on internal medicine for specialists, and Dr. Batson was there, and he said that although classically in neurology the exam tells where and the history tells what, in dementia the history usually tells where as well as what. And I think that's accurate. I think the history and mental status testing, but not so much neurological exam. So I just wanted to finish by showing you more paintings. So this is one of the latest ones. This is in 1999. And this is the last one that he actually drew. This is his last self-portrait in 2000. So if we compare the two between 1967 and 2000, it's really heartbreaking. So I wanted to end by what Enrico Fermi said. Before I came here, I was confused about this subject, but now having heard your lecture, I'm still confused, but at a higher level. So if you have any questions, I'd be happy to answer them. Yes?
Could you help us differentiate exactly between mild cognitive impairment and dementia? What's the cutoff?
Yes. So it depends on what we're looking at. In general, what we look at is that patients have mild cognitive impairment. They don't score in the normal range for any of these tests, but they are independent with their with their activities of daily living and a lot of their instrumental activities of daily living. When it was kind of what Dr. Helen was mentioning earlier, when we go into a situation where the patient tests abnormally at these tests and starts having functional deficits, then we're looking more at the diagnosis of dementia. Mild dementia as opposed of mild cognitive impairment. The cutoff for scores is not as black and white. In general, on the MoCA, we think that, and on the mini-mental, the scores between 26 and 30 are considered normal. What's below 26 is abnormal. We're looking probably between 24 and 26, sometimes 22 and 26 on the Montreal Cognitive Assessment for scores that are in the mild cognitive dementia, mild cognitive impairment range, and scores that are below that, more suggestive of dementia, again, if we also have functional impairment.
When you were giving the directions for the trails, and it uses the word ascending order, I find that that's not an accessible word. How much coaching is okay in terms of saying starting at the letter A and going up and ending here? How much?
I do that a lot. So because you can't, by the time you get to administer the MoCA, you get a good feeling about what your patient's level of education is. And I oftentimes just don't do the ascending order. I say going from low to high or something like that. That's part of the instruction. You start at 1, you go from 1 to 8, because you have the first ones are already drawn. So you tell them that you start at 1, you go from 1 to 8, you have to end at E.
Of the several screening tools, which is most likely to catch the cognitive impairment early?
I think that it's the Montreal cognitive assessment of the ones that were presented so far. It's the most sensitive in detecting mild cognitive impairment. Okay, thank you.
Thank you, Cosmina.